Well, welcome everybody to today's October OACS Forum Series session. My name is Jason Kim, and I'm the Director of OA Research Programs here at the Arthritis Foundation. We are trying to do more for OA here at the Foundation, and with the OACS Forum Series, we're trying to bring together researchers and investigators to help drive conversations about the progress toward new therapies into our first season of the OACS Forum Series, and have had great discussions like Does Strong Muscle Matter in OA with Eva Roos, RA Biologics in OA with David Felsen, Cell Therapy in OA with Scott Rodeo, and Tanezumab and Similar Emerging Therapies with Nancy Lane. So you can check out the latest updates on our program by the website link that we'll drop into the chat box. But I would also like to highlight that next month's military focus session is going to be led by Jody Buckwalter, and we are also planning a mini conference in early December, probably December 9th through 11th, and that'll feature two more forum series discussions, as well as video posters and some speakers that are rising stars in OA clinical research. So with those announcements out of the way, let me remind everybody of a few housekeeping items. So OA is a disease without borders, and we are proud to include many nationalities on this call. So in order to make this program available to people in all corners of OA research, the program is being recorded and links will be posted on our website in the coming weeks. Attendees are encouraged to submit questions to the panel via the QA chat function, but otherwise are muted. And we look forward to good questions for the panel in the discussion. If you have any technical issues on the Zoom call, please send an email to afscience@arthritis.org. Our staff will be monitoring the email line. Also, we have a networking breakout session immediately after the formal part of the discussion. So I hope you will join and interact with participants, attendees, and panelists. We have one of our very passionate patient volunteers, Patrice Johnson, who's agreed to host at least one of the sessions, as well as thomas.link, who is our discussion leader today, who will be on that line. So, I hope you will take the chance to say hello to them, as well as other colleagues that might be around. And now I'd like to hand over to Martin, who is an overall chair of the OACS Forum Series, and can maybe say a few words about today's topic and speaker. Martin, please.
Yeah, thanks very much, Jason, for putting this conference together today, and also thank you very much for making this OACS seminar series a quite educationally useful activity. I have the great pleasure to introduce today's discussion leader, Professor Thomas.link, who is a professor of radiology and chief of musculoskeletal imaging at the University of California, San Francisco. He is also the director of musculoskeletal and quantitative imaging research at UCSF. Thomas is a leader in research on imaging markers to predict and measure outcomes in osteoarthritis. And he's also done an impressive series of epidemiological factors, identifying risk factors for onset and progression of osteoarthritis. He's done a tremendous work also using data from the Osteoarthritis Initiative cohort. Also, thank you very much, Thomas, for your thoughts and time in putting what I think is a great selection of panelists and topics together for today. I think this is promising to be a quite exciting session today. So I hand it to you to introduce the panelists and set the stage for today's meeting. Thanks so much.
Mute. Okay. Can everybody hear me now?
Yes.
Yes.
Yes, we can.
Okay. Sorry, I think I was muted first. Okay, thanks so much for the introduction, Professor Lotz. It's a really sincere pleasure to welcome all of you to this OA Clinical Studies Conference, which is organized by the Arthritis Foundation. Today, the forum series will deal with the role of MRI, magnetic resonance imaging, in osteoarthritis and barriers to the implementation. We're going to cover both clinical aspects and research aspects. And first of all, I would really like to thank our program chairs, Dr. Martin Lotz and Dr. David Felsen, for their support putting this program together. They give us good advice to select our panelists. And then also many thanks to Dr. Jason Kim from the Arthritis Foundation for his hard work to organize our program today. So as I said, the focus of our today's panel discussion is the role of magnetic resonance imaging in osteoarthritis. And as I already mentioned, we'll discuss both clinical and research aspects. And based on this, we've assembled a panel which covers all aspects of these areas, which includes clinicians, radiologists, industry representatives. And so we can really cover this exciting topic from different angles. At the start, we will have 2 lectures to introduce the subject, which is standard for this series. So the first lecture will cover the radiology perspective. The second lecture will cover a rheumatologist perspective on magnetic resonance imaging. We have really experts in this field who will cover these areas profoundly, thoroughly, and will provide us with good advice for the panel discussion. First, Dr. Römer is going to speak, covering the radiology perspective. Professor Römer is a professor of radiology, is the chief of musculoskeletal research, and an attending radiologist at the University of Erlangen in Germany. And he also covers the aspects to some extent about clinical trials, being the chief medical officer and director of research of the Boston Imaging Core Lab. Professor Römer is an expert in osteoarthritis for many, many years and has profound knowledge not only about clinical aspects, but also about clinical trials. The second lecture is going to be given by Professor Tuhina Neogi from Boston University. She's a rheumatologist and one of the leading rheumatologists in the field for a number of years, and she has done wonderful work covering not only osteoarthritis, but also the imaging aspects of osteoarthritis. She's a professor of rheumatology and epidemiology at Boston University. She's also chief of rheumatology. And what really adds to her expertise, which is important for this panel, is that she's the past chair of the FDA Arthritis Advisory Committee. And she serves on the board of the Osteoarthritis Research Society International, the big society which focuses on osteoarthritis. So these are the 2 talks, and then we have a number of panel members who will be part of the discussion. First of all, I would like to introduce Dr. Xiaojuan Li, who is the director of the Program for Advanced Musculoskeletal Imaging at Lerner Research Institute at Cleveland Clinic. She is also the inaugural Bonodi Family Endowed Chair for Musculoskeletal Research at Cleveland Clinic. And in addition, she's also professor at the Department of Biomedical Engineering at Case Western University. Xiaojuan and I share a long history of working on osteoarthritis together, and we're currently chairing the MSK Biomarker Committee of the RSNA Quantitative Imaging Biomarker Alliance. And we're also involved in the ORZ Osteoarthritis Research International Imaging Interest Group. Next, I would like to introduce Drew Lansdown, who is an assistant professor in orthopedic surgery and who has a special interest in sports medicine and surgery of the knee, shoulder, and elbow. He really knows directly how it's like to deal with arthritic joints. He knows all the surgical aspects and can provide us with his perspective as an orthopedic surgeon. Moreover, Dr. Lansdown is also the co-principal investigator for the Arthritis Foundation Osteoarthritis Virtual Center of Excellence Clinical Trial Network. And in this way, he oversees clinical trials and can provide his expertise, what kind of imaging outcomes MRI, what kind of role MRI could play in this area. And then we have a number of people from industry who basically we cover all the big MR manufacturers. Maggie Fung is the Global MR Musculoskeletal Application Manager for GE Healthcare, and she has a lot of expertise with MR imaging techniques for osteoarthritis, and can share her insights from an industry perspective. We also have Ruud de Boer, who is an MR clinical scientist who has a focus on spine and MSK applications. He's working at the Philips MR headquarters in the Netherlands, and he served as Philips MR clinical science director for many years. And finally, we have Dr. Shodong Song, who is head of MSK research and development collaborations for Siemens Healthcare in North America, and he's specifically responsible for MRI research and development. So with that being said, I would like to introduce our lecturers. And first, Dr. Frank Römer is going to give his radiology perspective on the role of MRI in osteoarthritis and barriers to implementation. And I'll open the floor. Frank, the floor is all yours, and we're looking forward to your lecture.
I need the unmute as well. Thank you very much. Can you hear me?
Yes.
Okay, I just need to clean up my screens a little bit, and here we are. Well, thank you very much, Thomas, for the very kind introduction. It's really a great honor to speak and present today, not live, unfortunately, but in front of such a prestigious group of researchers, clinicians, and the Arthritis Foundation representative. Thanks also to Martin Lotz and to David Felsen supporting this series, which is excellent, and I followed a few of them already. So I will cover today within the next 15 minutes or so, I think, the role of MRI in osteoarthritis and the barriers to implementation. I will focus on clinical aspects. So this talk will not be explicitly about clinical trials or observational study. It really will focus on the clinical aspects. And I will start, let me see if I can, yeah, here we are. These are my disclosures. And I phrased and structured my presentation with some questions that I hope to be able not necessarily to answer, but to lead to a fruitful discussion afterwards. So do we need MRI today to diagnose osteoarthritis?
Sorry, Frank,
yeah,
your slides are not being shared yet.
Oh, I'm sorry. I'm going, oh, my slide, I thought they were, hang on. Okay.
Okay.
Now we see them.
Better now? Okay.
Yeah. We have them.
Okay. Full screen now?
Yes.
Okay, perfect. This is fantastic. Okay. All right, so I will continue. I will start off with my overview slide. I just need to minimize this one now. Okay. Is MRI needed to diagnose knee osteoarthritis? Is the first question I would like to ask. What about the differential diagnosis? Is there a role in establishing such a differential diagnosis when we talk clinically about suspected osteoarthritis? Is MRI needed to monitor treatment effects during the course of the disease? Is the third question I would like to ask. And then can MRI predict incident, meaning the onset of osteoarthritis and disease progression? And these are basically the four main questions I would like to pose and move on, then give a summary very briefly about available MRI methods and analytic approaches that we have at hand today in order to work with MRI data. And there's another disclosure. I will not cover in my presentation the technical aspects, and I know there are several representatives from the large vendors here, so there's plenty of opportunity to discuss that afterwards, but I will not cover that. And I will, as said, focus on the clinical application and the knee joint, because we have most information and most data on the knee joint. So I will start off with, is MRI needed to diagnose osteoarthritis? And I will start off with a recapitulation of the current diagnosis by the ACR. And you know, there are 3 different ways to diagnose knee osteoarthritis. One is clinical and laboratory, one is clinical and radiographic, and one is purely clinical. And I put a box around the only radiographic finding that appears in these diagnostic algorithms or definitions, and these are the presence of osteophytes, nothing else. So this is the current ACR recommendation to diagnose osteoarthritis. To illustrate that a little bit, what does that mean? So we still rely radiographically, or from a structural perspective, we still rely on the Kellgren-Lawrence grading scheme from 1957, which is very old. There's probably no other disease that diagnoses a structural disease entity with a classification scheme that old. And you can see here the definition of structural osteoarthritis is the presence of a definite osteophyte plus or minus joint space narrowing, but the definite osteophyte is the defining feature. To visualize that with some images, you see here the Kellgren-Lawrence grading scheme visualized from Kellgren-Lawrence 0, meaning a completely normal AP radiograph, Kellgren-Lawrence 1, meaning there are some tiny equivocal osteophytes that do not fulfill the definition of a definite osteophyte. Then Kellgren-Lawrence 2 has our definite osteophyte, and you can see that with the arrow here at the laterofemoral condyle. Kellgren-Lawrence 3 meaning joint space narrowing, and Kellgren-Lawrence 4 meaning bone-to-bone appearance. And this would be, again, the cutoff between no osteoarthritis and structural osteoarthritis. Another example here, when we look at a defined possible onset of osteoarthritis, it's very straightforward. We have an ACL injury here in a 28-year-old male. Baseline AP radiograph is normal. You can discuss if there's something very tiny here at the medial tibia. 5 years later, the follow-up image, and you can see that this person has developed definite structural osteoarthritis over time. We have our definite osteophytes here at the medial joint margin, and we have potentially some very tiny and discrete joint space narrowing here medially. So as I said, it's straightforward, but late in the disease. So if you ask that, this immediately will bring us to MRI. So if we are late with X-ray, why don't we use MRI? And I will move on with a population-based study, which is the Framingham osteoarthritis study. And we will look at knees that do not have any signs of osteoarthritis, meaning we must be much earlier than our definite osteophyte, meaning Kellgren-Lawrence 0. So these are structurally normal in regard to the X-ray appearance. And you can see this here by this landmark study by Ali Germasi performed a few years back, where he looked at subjects or participants in that observational study who had a Kellgren-Lawrence knee, and we were assessing structural morphology parameters in regard to MRI. And you can see that more than 90% have some feature of osteoarthritis in their knee joint. Does that mean that all these Kellgren-Lawrence 0 knees, this is an elderly population, 60 plus, have osteoarthritis? Probably not. So when you ask me, so we're using the old 1957 definition, do we have something more fancy, something newer, and taking MRI into account? The answer is yes. There was a consensus definition that has been published a few years back, led by David Hunter, where a Delphi exercise came up with this is a suggestion, I must say, that has been used in some clinical studies, which also requires the presence of a definite osteophyte and also requires full thickness cartilage loss. If only one of these primary features is present, there have to be 2 or more so-called group B features that you can see at the bottom part of the image, which is meniscus damage, which may be a subchondral bone marrow change or lesion, which may be superficial cartilage loss or bone attrition. So yes, we do have that definition, but it is not commonly used today in a clinical setting. So coming back to my first question, is MRI needed to diagnose OA? I think the answer is no. It's very clearly a clinical diagnosis, and Tuhina will talk about that following my presentation. And I think really it can be diagnosed clinically and with the help of an X-ray. So moving on to what about the differential diagnosis? Not every person that presents to our practices in the clinic has knee osteoarthritis, but has pain. So an example here, it's emphasizing the point that not all knee pain is necessarily OA pain. This is a 52-year-old female that came to the MRI scanner for medial-sided joint pain. You can see here several structural features. There's a meniscal tear here with a horizontal and also a radial component in the middle image, as you can see. And there are additional changes like perimeniscal synovitis, as depicted by these two arrows, and also periligamentous synovitis. So this is not necessarily osteoarthritis. There was no osteophyte and no joint space narrowing, but there are several structural features that may explain knee pain. Another example here is a 62-year-old lady, also presented with medial-sided knee pain. You can see a tiny horizontal degenerative meniscal tear here. I don't know, can you see my arrow, by the way? Thomas, yes, okay, so this, oh, that's very good. Okay, so you can see the tiny arrow, the tiny meniscal tear here, and you can also see some marked perimeniscal synovitis posteriorly. So what happened is the patient underwent partial meniscectomy, was better for about 2 or 3 weeks, and then suffered increasing pain again. After 6 months, a repeat MRI was performed, and that looked like this. So this is a very large bone marrow edema change here at the medial femoral condyle and a subchondral insufficiency fracture here directly beneath the subchondral plate. So this is severe knee pain, but not explained by osteoarthritis. In this case, there was a partial meniscectomy, but no features of OA at this stage. And a final example I would like to give you is this example here. Patient, 53-year-old male patient, spontaneous knee pain without a episode of trauma or overuse, presented to the practice for lateral-sided knee pain, and this is what we saw on the MRI. And again, you can appreciate here a very large bone marrow change covering the entire epiphyseal lateral femoral condyle, as well even as some soft tissue inflammation here in the paracondyle area in those soft tissues. And this is what we call transient bone marrow edema syndrome, and used to be called transient osteoporosis, which is exactly the same, somewhat mysterious entity. So I just wanted to emphasize here that not all knee pain that we see in our practices is osteoarthritis pain. So the question was, do we need it for the differential diagnosis? I think MRI can be very helpful. But as said again, often the diagnosis is clear, and some of these differential diagnoses are relatively rare, such as the one I just showed you, which was transient bone marrow edema syndrome. Moving on to the third question, is MRI needed to monitor treatment effects? And there it gets a little bit more tricky because we are entering the arena of clinical trials. This is a very illustrative example here I got from Felix Eckstein in Salzburg, who worked extensively using 3D methodology to segment cartilage from these high-resolution MRI images and use them as a structural outcome in observational studies as well as clinical trials. And a very recent landmark publication came out last year, where for the first time it could be shown that a so-called DMOD, a disease-modifying osteoarthritis drug, might have some positive structural effects on cartilage, and this was shown with such a 3D morphometry. So in this case, to see if a DMOD is structurally working, MRI might be very helpful. Unfortunately, in this trial, no superiority could be shown for treatment compared to placebo in regard to the clinical outcomes. Another example here, maybe is MRI helpful to help us to define patients that may profit from a certain treatment. And I give you the example of intraarticular corticosteroid injections, which have been in discussion for a little bit now, because there have been some case series and some suggestion that these might be not always have positive effects and might have some adverse outcomes on certain patients. And in that case, an example I will show you here, This is a patient that presented for IACS injection, a 45-year-old male patient without osteoarthritis, maybe minimal joint space narrowing immediately, but that's very questionable because this is not a standardized X-ray. And what you can see here is also a subchondral insufficiency fracture and marked bone marrow edema. The patient underwent injection, and this is what we saw 6 months later, which was rapid progression of the medial osteoarthritis, joint space loss, diffuse cartilage damage, and again, a minimal subchondral insufficiency fracture here. So maybe this patient should not have undergone intraarticular steroid injection up front, and MRI might be in a position to help here, but this is more speculation than based on data at the present time. So the question was, is MRI needed to monitor treatment effects? And my answer would be, not today in the clinic, because we still do not have an approved D-mode. But yes, in clinical trials, there's a very important tool, and potentially MRI may disclose or predict some adverse events of certain treatments. And you remember my example I just gave you. So moving on to the fourth question, can MRI predict incident osteoarthritis and disease progression? And there we have plenty of data, mainly from observational studies, including the Osteoarthritis Initiative, the MOST study, and other ongoing osteoarthritis studies that have applied MRI. This is just an example here from our group in collaboration with an international group led by Ken Kuo and David Hunter, the so-called POMA study, where we had where we used a matched case control study within the osteoarthritis of patients that developed OA over the observational period of 4 years. And this is an illustrative example, baseline image completely normal. The middle image shows you an incident meniscal tear here with a radial component, some minor cartilage loss. And after 3 years, an incident cartilage defect here at the medial femoral condyle. So when we look at cases and control, this is a busy slide, excuse myself for that, but it very clearly shows you the prevalence of the so-called MRI biomarker here in the left column, being separated by cartilage, bone marrow lesions, meniscal damage, and inflammatory markers. And we compared the controls with the incident radiographic osteoarthritis cases, and you can see that the presence of these MRI features is definitely higher by about 2 in the year of developing, or in the year prior developing structural osteoarthritis. And this increases with the number of features present, meaning if you have once you have a meniscal tear plus cartilage damage plus a bone marrow lesions, your risk of incident OA markedly increases over that period of time. Another example here from the so-called FNIH study. The FNIH study is also a sub-study of the Osteoarthritis Initiative that has been defined by very clear outcomes, meaning some of these subjects developed or progressed in regard to structural or clinical osteoarthritis over time, and others did not. And there we could show that 24-month changes in cartilage, thickness, surface area, inflammatory markers, and meniscal morphology independently was associated with OA progression. So the question was, and these were just, I could add here multiple other studies because many researchers have looked at these questions. And I think our answer today is, can MRI predict incident OA and disease progression? It has to be yes, very clearly, but clinical relevance of that is unclear, as again, we probably, I say that in a provocative fashion, we cannot modify the course of the disease. Probably Tuhina is contradicting me here, and I'm looking forward to that discussion. So summarizing that, MRI features of OA. So this is our X-ray, just to really visualize that again to all of you. This is an X-ray, and the X-ray shows you bone. There are osteophytes at the joint margins. There is some joint space narrowing medially, but osteoarthritis means a lot more. And you probably have seen this slide or similar animations. There is cartilage here in between the two major bones, the femur and the tibia. We have the meniscus as the structure. We have subchondral cysts. We have the ligaments. We have the subchondral bone in general with bone marrow edema, the capsule. We have joint effusion, synovitis, and we have periarticular cysts. So there's a lot more, and we do not forget about the muscle. And we had a session in this series about the role of the muscle and the importance of the integrity of muscles for osteoarthritis development and progression. So I will finish my talk with a summary of the currently available methods of OA assessment. So there are different methods available, and it might be, and Again, have to apologize if I did not cover everything, but the main ones that are being used today in observational studies and clinical trials are these. One is quantitative analysis. I mentioned that very briefly in conjunction with the Sprifermin trial. Then we have the so-called semi-quantitative analysis, which is based on ordinal scoring of multiple joint features and multiple joint tissues. We have compositional analysis, and Xiaojuan Li and thomas.link have worked a lot on that topic, meaning techniques like T2 mapping, T1 row, Degemerik, etc., that can show you the ultrastructure of a joint tissue and mainly cartilage, or it has been applied mainly to cartilage. Then we have more recently bone shape, which can be extracted from 3D MRI images and showing you the change of bone shape over time, predicting also incidence and progression of OA. And finally, metabolic imaging that I will not cover in detail, but PET CT and PET MRI has been used increasingly, not a lot, but increasingly in a research setting. And I will just pick two of these because they are maybe not so easy to grasp. One is the semi-quantitative analysis part. Just to explain very briefly, what does that mean? It means that, as I said, it's based on scoring, ordinal grading of features. What we do is we subdivide the joint into multiple subregions or locations depending on the features. So osteophytes are scored at locations, bone marrow lesions and cartilage are scored at subregions. And then we assign grades for different features. This is an example from the established Worms scoring system. A more newer system that is commonly used today is MOACS, but you can see here it goes from 0 to 6, depending on the amount of damage involved in a certain subregions. If it's only superficial, if it's full thickness, if it's more focal or widespread, etc. I do not need to go into detail here. And in the interest of time, I will move on directly to compositional MRI. And there are a lot of acronyms that you probably heard before, but are very difficult to grasp. And I will move on to those very, very soon. But basically, what do they do in regard to cartilage assessment? Cartilage, as you know, is only consisting in 5% of chondrocyte. The rest is the extracellular matrix. Consisting of water, type 2 collagen, and proteoglycans, and the different techniques that we have available today cover different aspects. And these are these acronyms I was referring to. So Degemerik is a technique that is based on IV intravenous injection of gadolinium. And then you have diffusion of that contrast agent into the cartilage and gives you a very good idea of proteoglycan content. T2 mapping and T1 row, two more commonly used techniques, give you an idea of water content, collagen content, and orientation. And the other ones are more fancy and more difficult technically to apply, and most of the time used at more high field or super high field systems at 7 Tesla. The question is, and Thomas mentioned that briefly in the introduction, we have to work on reliability, responsiveness, and validity of these techniques because they are difficult to apply in regard that different scanners, different vendors, different site, the inter-observer reliability has to be standardized, etc. And the KIBA initiative by the RSNA is doing a great job here, and the current document is available for discussion at that website I put down here. Maybe we need to discuss that later on. So these are promising techniques. Their main advantage is probably in early OA when cartilage changes are still reversible. And I will summarize and come to an end. So MRI in osteoarthritis and the role in the clinic today. The first question, or we remember the question, we do not need it for a diagnosis of knee OA, but it can be helpful for the differential diagnosis and particularly rule out more severe potentially complications or disease entities that are maybe treated differently than our household osteoarthritis. In my practice here in Germany, we use it quite commonly, or the physicians, the referring orthopedic surgeons and treating physicians like to use it actually as a tool to discuss with the patients the amount of joint damage present. And a radiograph is not very impressive to the patient, but they say the MRI, once they have seen that, it may really work as a motivator to engage in non-surgical intervention, for example, such as weight loss. There is a potential role of MRI prior specific treatment to identify patients at risk that may or may not profit from such treatment, as mentioned before. And it is also used, again, here maybe the European perspective, in surgical planning. The surgeons often want to know, is the other compartment, most of the time it's the medial compartment that is involved, but is the lateral compartment intact? And can this patient profit, for example, from a hemiarthroplasty and doesn't need a full joint? And we can also rule out complications of OA, such as subchondral insufficiency fracture. And there is a potential role of quantitative MRI parameters in the clinical routine, but without available disease-modifying treatment today, that role, I think, is unclear. And I think we have to work and discuss how we can overcome that. And with that, I'm finished, and I thank you very much for your attention.
Thanks.
Okay. Let me unshare.
Thanks, Frank. This was a perfect introduction for magnetic resonance imaging aspects and applications from a clinical perspective, but also from research. So this was a wonderful start for gathering material for our panel discussion. And now I'm looking really very much forward to Tuhina's talk, because she's going to give us not the radiologist, but now the rheumatologist perspective, which is so important for dealing with our patient, for our management decisions in patients. And Tuhina, the floor is all yours.
Great, thank you. Okay, are my slides visible?
Yes, well.
Okay. Great, thank you. So thank you, Thomas, for the invitation, for putting this together. Arthritis Foundation, particularly Jason's really hard work in putting these webinars together, and David Felsen and Martin Lotz for chairing the whole series. So I'm very pleased to be following Frank, and you'll see that the rheumatologist perspective and the radiologist perspective is fairly well aligned. Oh, okay, so these are my disclosures. So as Frank said already, the diagnosis of osteoarthritis from a rheumatologist perspective is primarily based on history and physical exam. And the classification criteria from the ACR that Frank shared are really criteria to help guide inclusion into trials or studies. So from a clinical perspective, obviously we have to think about the particular epidemiology in the region that you're in and particular features of a patient. Classification criteria are focused on the most common features that are quite prevalent, but will not capture the whole spectrum of a disease. And so based on history and physical exam, we have a good understanding of what joints we typically expect to be involved in osteoarthritis. And because the history and physical exam are usually sufficient, we don't think about imaging being necessary for the diagnosis of osteoarthritis. However, if there are atypical features on history or exam and it's not quite fitting a diagnosis of osteoarthritis, that's when additional testing, including a radiograph or advanced imaging, may be warranted. In terms of understanding someone's cause of pain, as Frank already reviewed, the paper by Ali Gramazi and colleagues looked in the Framingham study, which is a community-based cohort unselected for pain, and there was a high prevalence of MRI features in knees without radiographic OA. But what's important in thinking about MRI for understanding of cause of pain across a sample of individuals is that the knees with pain and the knees without pain had a similar prevalence of any MRI abnormality. And I think this becomes even more important clinically when we think about this study that Martin England did, again in the Framingham study. He took people who had radiographic OA in the Framingham study and looked for people who had meniscal tears on the MRI versus those who had no meniscal tears. And when he looked at the presence of frequent knee symptoms, he found that the prevalence of frequent knee symptoms was similar in versus those who didn't have frequent knee symptoms among people who had one or more meniscal tears. So raising the question of, in osteoarthritis, are menisci really contributing meaningfully to symptoms, or are they a reflection of the overall disease pathology occurring in the joint? And so one question that we think about when ordering tests is, will that test cause harm? Well, MRI has no radiation, so that's one benefit. It is expensive, and at least in healthcare systems where there is no universal healthcare, the coverage can vary and can impact a patient's finances if they don't have coverage. But I think the real key question for a clinician is, when you're ordering a test, what is the purpose of that test, and what are you going to do with those results? And so I think one of the biggest impacts of MRIs in a clinical setting to understand what's going on with the patient's symptoms in the setting of osteoarthritis has been a high proportion of patients receiving arthroscopic partial meniscectomies. And it's estimated that there's over 700,000 procedures per year in the US. Now, I'm speaking specifically about osteoarthritis here, not for young athletes who have acute injuries, but really talking about osteoarthritis-related meniscal lesions. So there have been a number of studies conducted over the last 20 years, and this is from Teppo Järvinen's group in Finland, the Fidelity trial, which randomized individuals to arthroscopic partial meniscectomy versus sham surgery. And in the initial report over the 1 year, there was no difference in knee symptoms between arthroscopic partial meniscectomy versus sham surgery. And these similar findings have been noted in a number of other trials, including comparison arms that include usual care, physical therapy, lavage, etc. So for arthroscopic partial meniscectomies, is it just placebo? Well, so there was a lot of thinking that, well, it might help, but very little attention was paid to what about harm. And so recently we've got some longer term follow-up from Fidelity, which was published recently, that showed that there was an indication of slight increased risk of OA progression at 5 years. And similar to this finding, the Meteor trial, which randomized participants to arthroscopic partial meniscectomy versus physical therapy, at 18 months, Jamie Collins and colleagues reported an increased risk of cartilage damage assessed on MRI. And also recently, the same group reported an increased risk of knee replacement at 5 years among the group that underwent the arthroscopic partial meniscectomy in the blue line versus physical therapy in the red line in this intent to treat analysis. So, I think in thinking about the downstream consequences of ordering a test, what are you going to do about the results? And is the intervention going to help? And importantly, is there potential for harm? So again, going back to a clinical scenario in which we've diagnosed someone with osteoarthritis and now they present with more pain. And will imaging help here? So we know that osteoarthritis pain fluctuates over time, that patients experience flares. I think for me as a clinician, what prompts me to think about imaging, including advanced imaging, is whether their pain is out of keeping with their typical osteoarthritis course. And secondly, is there a patient who's been labeled as osteoarthritis, but they're an atypical patient? For example, I think, Frank, one of the examples you provided was a 45-year-old with some knee pain. Do they really have osteoarthritis? Some patients that we see are in their 30s, have been labeled as osteoarthritis. And so I think in those cases, when it's an atypical patient that we don't typically think of in the epidemiology of osteoarthritis, or their pain is really out of keeping with a typical course of OA, we want to think about what other things might be going on. And then Frank also shared the more recent concerns about intraarticular corticosteroid injections and whether or not they might be contributing to joint pathology. And this is the case series that he cited as well that was published last year. And I'm just going to show an example of a case that Dr. Akira Murakami shared, where this was an individual prior to joint injection. And this was 1 year later, and these are the MRI findings. And he said that there was something here that is of concern. So for me as a rheumatologist, I don't know that I would necessarily, number one, be obtaining an x-ray before doing an intraarticular steroid injection. That just hasn't been part of our practice. And even if I were to have done so, I don't know that I would necessarily have decided that this might preclude the use of joint injections. A big issue is that this was a case series, so it's not a controlled study. And so we don't know about confounding by indication. So was it really the injection that led to this bad outcome, or was it the underlying cause of the original pain that was the pathology that led to this outcome? And so I think this is where it's very challenging for us to now understand what is the role of imaging, because we don't actually know what the prevalence of something like this is, and we don't understand whether or not the pre-intervention imaging would help us detect this problem, and whether it would preclude us from doing a joint injection. Now, in speaking with some of my colleagues, including Dr. Gormazi and Dr. Murakami, some of the anecdotes and examples are of people who probably have had pain out of keeping with their typical OA course, or might be a patient in whom the diagnosis of OA should be questioned and other diagnoses should be sought. I do think eventually we will be moving into an era where advanced imaging such as MRI may be useful in selecting targeted therapeutics. So for example, if we get to the point where we have lesion-directed therapy, then we would need to know if the lesion is present to select that therapy. So, so far, bone marrow lesions and synovitis effusion are the most promising candidates where this type of approach may be used. For example, for bone marrow lesions, there was a specific patellar knee brace that seemed to reduce bone marrow lesions in the patella. There's also been zoledronic acid trials targeting bone marrow lesions. So we might get to the point where lesion-directed therapy would warrant imaging ahead of time and potentially for monitoring. And then similarly for synovitis and effusion, although we don't have anything specifically now, there are some promising signals. For example, the CANTOS trial of canakinumab in high-risk cardiovascular patients, participants, demonstrated a lower risk of joint replacement over time, and whether that's related to symptom modification or reducing pathology like synovitis and effusion in the joint is unclear. And then finally, with the advent of, the potential approval of NGF agents, where there is an adverse joint safety effect that we will need to figure out how to risk mitigate for in screening for appropriate patients and follow over time. It's unclear at present whether or not advanced imaging like MRI will be needed to rule out particular pathology before choosing an agent. And then I think there's clearly more need to understand what the potential of interarticular injections might be on joint pathology, given that we only have observational data, and the clinical trial data, for example, the Tim McAlinden trial that was shared, did not show any relation of that minimal cartilage change or cartilage difference with pain or function outcomes. And so I'm just going to end off with moving on to research needs. So, what I've tried to focus on so far was the practical aspects of clinical applications, but I really want to emphasize that MRI has a really important role in addressing the numerous research needs that we have in osteoarthritis. And this stems largely from the fact that radiographs lack sufficient sensitivity. So we've been focusing on, for example, in studies looking at risk for progression or understanding risk for progression, we're starting off with KL2-3 knees and looking for progression to basically end stage. That's like taking someone who has already bad congestive heart failure and following them to the point where they need a heart transplant. That's not going to be the best way to gain important insights about how to minimize disease progression and minimize incidence. And a challenge with this approach has been a methodologic issue of collider bias, which Yuqing Zhang and colleagues have published on, where we will be missing the association of a risk factor with progression of OA by focusing on those that start off with KL2 or 3, because that risk factor might have led them to develop OA to begin with, and in this kind of a study design will miss that signal. And to overcome some of that challenge, Jeff Dribbin and colleagues have defined accelerated OA using radiographs starting before KL2, but it's still fraught with challenges because radiographs lack sensitivity. We've had challenges in understanding OA etiology because, again, we're picking up OA in these studies at an advanced stage already. We need to move much further back in the time course to understand risk of osteoarthritis. But how do we define early osteoarthritis? As we've shown from the Framingham study, MRI lesions are quite prevalent even in KL0 knees. There is that early MRI definition, but needs to really be validated with longer term clinically relevant endpoints. And then just as we know for other organs and tissues in the body that there are changes with aging, how do we differentiate healthy aging or normal aging of the joint versus osteoarthritis? So we know with bone mineral density, there are declines in bone density with time, with age. We know there's declines in renal function with age, declines in muscle structure, integrity, and function with age. So we need to have more understanding of the natural history of the joint with aging, and advanced imaging would be necessary for those types of insights. One of the challenges also with defining early osteoarthritis is that there haven't been enough studies with MRI with long-term outcomes to help define that. So there is an effort to define early OA classification criteria, but one of the challenges is the need for a number of cohorts to have similar data collected and to have advanced imaging and to have long-term data. So it will be very challenging to develop validated early OA definitions without that kind of uniform data across large numbers. We have had years and years of many failed trials in OA, and whether or not the trials have failed because the therapeutic agents were not effective, or is it because our outcome measure using joint space on radiograph has failed to detect promising signals? And recently there was an update to the FDA guidance about structural endpoints for D-mode trials. And I think I saw Dr. Nikolai Nikolov on this webinar here today. So perhaps in the discussion we can broaden this, but we need more research in helping to define MRI endpoints, given that joint space on radiograph has not been fruitful to date. There have been a couple of papers on this topic on study design by Virginia Krause and colleagues, and then a summary of the FDA ORSI workshop that addressed this that was just published by Jeff Katz and colleagues recently. And then there's a lot of interest in prediction. So Frank already talked about prediction of incidence of radiographic OA. And this is an example of a paper in which latent class analysis was done to try to understand which cluster or grouping of features might predict radiographic OA. But beyond predicting onset of radiographic OA, what's more clinically important for us is to understand the course of OA over time. And joint replacement is an important clinical endpoint, and Frank Romer and colleagues have published on this. But there are a numerous number of studies that we need to understand to understand the different rates of progression, the different patterns, the different trajectories that people have, and can we identify risk factors for those different trajectories? Can those different trajectories help us identify appropriate people for clinical trial enrollment? Are there different phenotypes that would have different treatment implications? So, there are a whole host of reasons why we do need MRI for research purposes. And then finally, just a plug for an ACR abstract in which we've used machine learning to predict TKR as an outcome using clinical and imaging data input. And then Frank already reviewed a few examples with semi-quantitative and compositional, and I just wanted to give a slide to 3D bone shape from MRI as an example. So this is work that's largely led by Mike Bose from iMorphics, and we showed a few years ago now that bone shape can predict incident radiographic knee-OA even 4 years later, and even among KL0 knees. They've shown that this approach also predicts knee replacement. And more recently, I think even though this trial did not meet its primary endpoint in this Cathepsin K trial, it was interesting to see that medial femur bone area was able to differentiate from placebo. So the dotted lines are the treatment arm, the solid line is placebo. So this was able to differentiate from placebo at about 24 weeks, and cartilage thickness in the central medial femur was less robustly able to do so. So this is just as an example that using advanced imaging can help increase sensitivity to change. Certainly we would not expect any such separation with radiographs alone. So it can help make clinical trials more efficient and help reduce sample size if we were to expand our use of advanced imaging. And we need more research to help demonstrate that these imaging biomarkers are related to clinically relevant endpoints so that the FDA can receive support and guidance for using these types of endpoints in drug approvals. So in summary, the rheumatologist's perspective, at least in my opinion, was very similar to the radiologist's opinion, so I agree with Frank. I hope I've impressed upon everyone here that we need more development of MRI as a tool for gaining research insights and to support structural endpoint assessments in trials. And for now, there's no role for routine use of MRI in clinical practice, but there are definitely specific instances where it can be useful. And then just before I sign off, I just want to have sort of a shout out for a couple of things. So I had the pleasure and honor of participating in a joint action podcast where we discussed exactly these things, how to diagnose osteoarthritis and what is the role of imaging. And I just also want to advertise the International Society of Osteoarthritis Imaging, which has recently been approved for its tax-exempt status. So there will be much more coming out from the society. And this is a society that over the last 13 years has hosted the International Workshop on OA Imaging, which is one of the best conferences to attend for someone who's interested in OA and imaging. And where else would you be able to, where else other than this kind of a conference would you be able to get to see Ali with Anne of Green Gables braids? And so with that, I thank you, and I think we'll move on to discussion.
Thanks so much, Tuhina. This was a wonderful presentation, and I think now we have a lot of food for thought, and we have a lot of material for discussion. Now we've jump into the discussion. What I would like to do is also, since we talk now radiology perspective, we have a rheumatologist perspective, just to get an additional perspective how to deal with osteoarthritis. I would like to ask Drew Lansdown, who is an orthopedic surgeon. Maybe you can briefly give us your impression. So how do you see your role in treating osteoarthritis? I mean, we've heard a lot, for example, about meniscectomy, and we have heard that meniscectomy can sometimes cause more damage than good. But so the orthopedic surgeon clearly have a very important role also in guiding treatment. And I was wondering whether you could also give us your perspective.
Thanks, Thomas. And thanks so much for having me as a part of this. And Frank and Tuhina, really enjoyed your talks. Those were excellent. And I think I agree with Tuhina that, with the concept of we need to make sure we have an actionable finding from our studies. And oftentimes with an MRI and osteoarthritis, there may not be something that we can, modify surgically or in treatment in the progression of osteoarthritis. So in the, more severe cases, I agree there's not that defined role for MRI. And in the routine clinical application. I think some of the things that we're really focused on in orthopedics right now is like especially pathology like a meniscus root tear would be one example, where oftentimes patients may have more vague symptoms and a well-preserved joint on radiographs, and then if it is undetected, can often have rapid progression of degenerative changes. And I think that's something that we've made improvements in our techniques and in our repair strategies. And that's one condition where I think we really can modify the natural history. Left alone, we see progression to total knee replacement at more than 50% in 4 or 5 years. And then with treatment, we can really lower those rates with a anatomic repair of the meniscus root. And then I do agree that like the role of a partial meniscectomy, I think our field is hopefully utilizing a lot less with all of the data that we have. I think there are times where meniscus surgery is still indicated, and I think especially going forward, there are many who are being just more aggressive with repairing the meniscus when we can. So trying to preserve the meniscus and its chondroprotective effects, and we've new implants, new techniques that may allow us to keep rather than resect the meniscus when there is tearing. And I think it'll be exciting to see if those treatments are improving outcomes and preventing progression of osteoarthritis or other degenerative changes in the knee.
I think what I learned from you guys was always that you said if you see a meniscal tear in the elderly, both Ben and you, Drew, you said that you should be very careful because this patient, if you resect the meniscus, this patient may go on to insufficiency fractures. And I think that's what we've nicely seen. Frank has demonstrated a number of cases where, in fact, one patient had, after meniscus resection, he had developed a insufficiency fracture. And these insufficiency fractures are pretty bad because they may go on to total joint replacement. But then on the other hand, if we know we have them, we could potentially also treat them in terms of non-weight bearing. Do you see, in terms of, we've talked a lot about insufficiency fractures, and do you see also, how do you see your role in terms of treating insufficiency fractures and what you can do in order to prevent damage once you diagnose them?
Yeah, and so when we detect those, usually on the MRI, and it usually seems to present as kind of pain out of proportion for any kind of injury or any radiographic explanation. And I think I'll have a suspicion for an insufficiency fracture with that type of patient presentation. And I think the MRI can really help localize and characterize the extent of the injury in that setting. And then I think getting those patients on crutches, protecting their weight bearing, or using an unloader brace is a common technique if they're able to walk with that. But trying to allow them to have pain-free ambulation, I think can reflect if the joint is tolerating the amount of load placed across it.
Thanks. That's very good. If you think about MRI and as you use it in clinical practice, both Tuhina and Frank have shown a number of technologies. Some of them were more research tools. Some of them were more clinical tools. In your daily practice, in your clinical practice, what do you think is most helpful for you? What's your ideal type of MRI you want to get?
For most, we are just standard clinical qualitative MRI. We do have the ability, here at UCSF, we're fortunate to be able to obtain T1 row, T2 mapping, and have post-processing even in the clinical setting. And I will use that on cartilage restoration patients, some post-ACL patients. And I think, similar to what Frank had brought up about, using the MRI to counsel patients on lifestyle changes, I think you can present the patients with a detailed map of the cartilage health. And even if we don't have the, the perfect therapeutics to intervene on those changes yet. I think saying to that active post-ACL patient, hey, we see some breakdown in this area, it seems to be accelerating, might be worth modifying activities to preserve knee function or focusing on weight loss if that's an important factor for them.
Okay, great, thank you. So I think I would like to come back to both Tuhina's and Frank's talks. And I think what I've heard was a little similar to what EULA recommended in 2017, that they said, okay, if you just have your standard osteoarthritis, we don't really need imaging. But in atypical presentations, then you need imaging, and then that's when imaging is recommended. And both of you have shown some cases which were pretty impressive. What I always wonder is that sometimes if you have a patient who presents and who may just have findings, which, I mean, it's very hard to nail down. Is there a strict definition for atypical presentations? I mean, maybe it's a lot of pain, but I was wondering whether there could be, can we drill down on these atypical presentations and say, okay, these atypical presentations should be an indication to perform an MR? And maybe both Tuhina and Frank, you can say something about that.
I think, if I may start, Tuhina, I think it's basically pain out of proportion, to me, pain out of proportion, or a suspicion of something that is not 100% clear, as Tuhina showed in her slide where she shared that X-ray, a very tiny structural abnormality that is, that is evident, but maybe to the non-expert very difficult to put in a box, and then MRI may help very much. And the other thing, atypical OA is first no OA, so people are labeled as having OA, but in reality, as I showed also in some of my examples, they do have something else. OA is something very easy. Everybody above 50 has OA if you have knee pain, but that's not correct. There's much more to that. And if I have a person, and I think we still need the X-ray to understand, is this advanced established disease, or is this something else? If it's not advanced, or if it's not established disease, if it's basically a normal knee or something else that we don't really sure about, then I think you should be very suspicious and think about something else. And in that case, most of the time you will need an MRI to rule out some of the more malignant terms or malignant diagnosis, such as subconjugal insufficiency fracture. Drew said meniscal root tear, very important because it's very detrimental to the joint health, or other causes. So this would be my answer, but I don't think there's a clear definition in regard to that.
Yeah, Tuhina, do you think we could develop criteria, clinical criteria for these cases of atypical presentations? Because sometimes I'm not sure whether our standard rheumatologists are so familiar with these atypical criteria and to even give guidelines. Okay, these are the atypical presentations where we need the MR.
Mm-hmm. Yeah, I also feel that I don't use specific criteria. It's sort of on an individual patient basis. And I think from a research perspective, sort of systematically understanding what are the features and symptoms that people are having prior to developing those outcomes would be helpful. I think one of the challenges with the Compo case series is that because they were being seen for intervention, like an interventionalist radiologist guided injection, the preceding, like exactly what those symptoms were, exactly what their course was, et cetera, is lacking there. And so without knowing what the prevalence is, it's really challenging to come up with an algorithm to say, this is what we need to be doing, and these are the criteria we should be thinking about. There are many rheumatologists and radiologists on this webinar, so I would invite people to share their thoughts on how they address this issue of identifying pain that's out of keeping with what you would be expecting, or an atypical, patient presentation. I think the other challenge for me also is so yes, there could be one of these types of things. We also want to just rule out that they don't have it, apart from something like subchondral insufficiency fracture, or what I guess we used to think of as SONC, if we could see it on the X-ray. Sometimes our patients are labeled as OA, but they have gout or rheumatoid arthritis or something else. So I think we have to keep an open mind when we're evaluating our patients and when they have pain. And I think this case series has just given a little bit of pause to think about, why are you giving that intra-articular injection? Do you think this is really part of their typical OA course? And Frank and Ali and David Felsen and Jeff Katz, and I think Ken Kuo and Phil Conahan, were all part of a paper that was recently put together to discuss this issue of what is the role of imaging, particularly with intra-articular injections. I see Ali Gormazi's hand is up, so I will invite Ali to unmute himself.
Ali, can you hear us? Can
Yes, I unmuted myself. Thank you so much. This is a quite amazing discussion. I love this because it's always the same thing, what we're gonna do here and what we can help with. But let me maybe add actually something about the discussion about pain and out of proportion. I do think at this point, what I learned from my colleagues, Tuhina, David Felsen, and others, that OA, it's waning and waxing. And it's usually not really going that abrupt. You don't go from 2 to 8, 9 in few days. And that's really what I saw in my clinic. I really had this discussion many times, and it triggered me to ask and request. I called actually the physician in charge, and I said, listen, I don't think your patient is having actually a pain that I can, say this is, or, I don't see this pain really osteoarthritis pain. And I explained this, I said, because I always was told that it's really waning and waxing is going very progressive. So you ask the patient, he tells you, okay, I still have pain. I used to have pain for the last 3, 4, 5 months, but now it's going from, and you say, okay, from 0 to 10, that's actually the VAS, which is the most easiest and the one that probably be easy for the patient. If he said going from 2 to 8, 9, then that's for me really an alarm that there is something happening there. So that's one point that I want to just really share, because from the clinical practice, not really from the research perspective or anything else, just clinically, and I know that I called once at least, Tuhina, and at least twice actually David, for the same purpose, because they taught me this. So I think it's a very important point that you remember that this is not really a pain which is out of proportion, meaning going from 2, 3 to abruptly to 8, 9 in few days.
Yeah. Ali, I think what you're bringing up here is super important. And I think that we have a panel here which has so much expertise. And I think that really what we need, and that's of course also the long-term goal of our panel discussion here, is really to define these criteria. What you were mentioning, Ali, okay, the pain goes up to 9 and 10. What Frank was mentioning previously, okay, out of proportion. But what I also think is missing is that a lot of radiologists nowadays are not experienced with plain films. And what Tuhina nicely showed in her case report was, okay, that already looked like a focal osteochondral fracture on the radiograph, but it was still not considered as a contraindication for giving an intra-articular joint injection. And it should have raised some alarm bells. And I think what we need is more teaching. We need that radiologists are more familiar with radiographic findings. And I see, Ali, you're on the same page. Yeah.
No, 100%.
Yeah,
so I remember I was sitting actually once with Mark Horberg in a meeting, and I showed them actually a subchondral insufficiency fracture, a case of normal X-ray, and next to it really out of proportion the small fracture. And he told me, do you think radiologists will know this? I said, I do think it's going to be very difficult, and we need to teach them. He said, so before you teach as a rheumatologist, maybe you have to go and start teaching your colleagues. That case that Tuhina showed, it was missed by someone that is really clearly a very good MSK radiologist that we never miss it again because it's lessened. But of course, I have a little bit more experience in that actually really dilemma of how you see things, etc. In the past, we looked at that as a small maybe attrition, irregularity, etc. But the question is, and Tuhina can just maybe show the examples again, is that there is that irregularity of the bone. There is a small really sclerosis, but the joint space is almost normal. There is even no actually osteophyte in the same medial aspect of the tibiofemoral joint. So those are questions that you, all of us, meaning the professors there that sitting there, they really need actually to teach our actually colleagues. You see it. So again, you see that the first one, you see the irregularity, but the joint space is absolutely normal. So why someone will have actually that irregularity and subchondral sclerosis minimal? That was really a real SIF that we missed, unfortunately, and we injected the patient and we ended up having a collapse of the joint. As you can see, no cartilage anymore. Everything is just done in 6 months. So we need really to be careful with those small signs, and we need to maybe spend a little bit more time on x-rays ourselves to start with us, with the radiologist clinically. It's really extremely important because we have actually the advantage to see this every day, etc. And then we can probably bring those more teaching and more our knowledge to rheumatologists and orthopedists or our colleagues, in different specialties. Unfortunately, we're not giving actually the X-ray the momentum, the time that it needs for interpretation.
I think one of the other challenges in interpretation here is we don't know, in a trial, we'd have a better chance of addressing this question, but we don't know what would have happened to that joint if it hadn't gotten the injection. This could be the natural history of that lesion. And I think, and I would invite like David Felsen and Jeff Katz. I'm just trying to see what other rheumatologists are here. I kind of feel like one of the reasons we may not see this as much in rheumatology, our feeling is if this were such a big problem, we'd see it a lot. But I think probably part of it is that the selection that we go through for who is getting an injection. So I invite, I'll just call upon David first, if you'd like to comment on this, because also you have an important ACR abstract that's also looking at this question.
Hi, I'm not sure I have a whole lot to add. I mean, I think the idea here is that the troubles that have been seen with intra-articular injection are likely to be because people got post-hoc injection films and the abnormalities were likely present before they ever got the injection. The abstract you're talking about is from Justin Bucci, who's one of our junior faculty, and it suggests comparing corticosteroid injection patients in OAI, subjects in OAI, to those who received HA injections, that there's just no difference in the rate of progression, and there's no difference in the rate of knee replacement later in those two groups. It's not at all. I mean, the rate ratio is 1.00. So what that suggests is that steroids really, assuming that HA has no particular risks, that steroids really aren't risky here. But I think what's needed is some pre and post information, and that's missing to some extent. The other thing, I think, if we're talking about clinical scenarios where there's maybe a little more concern about steroids and their risk is in hips than in knees. I think the data we're seeing in OAI suggests there's really not any increased risk in knees where the subject has reported getting either one or repeated steroid injections.
Jeff?
Yeah, I have been interested in this question of how frequently do individuals sent on, let's say, to physical therapy to treat knee pain, presumably OA, actually have a subchondral insufficiency fracture, because as Drew points out, you would generally treat them differently depending on their level of symptoms. You would have them do some degree of non-weight bearing. So we had the opportunity to make an observation as we're enrolling into a randomized trial of individuals with suspected osteoarthritis and meniscal tear who want to enroll in the trial, whose physicians don't see a need to get an MRI, and of course they rarely do. They're being treated non-operatively for meniscal tear. So we got MRIs in order to qualify them for the trial. So in about 250 such cases, we identified subchondral insufficiency fracture in about 3.5%. So it's a small number, but non-zero, and in most of those instances, the clinicians would alter, treatment, would have them do less weight bearing. So it becomes then an interesting, just question of, in that small but not negligible numbers, there a role for MRI, and are there features of those people that might have you get MRI in a subset? And we don't really have enough of them yet. There's just 9 or 10 to be able to examine that question. Who were these people in terms of their features? But it's probably the first data that I'm aware of where we can quantify the risk. It's a few percent.
Yeah. Thanks, Jeff. This is really very important information, and it's going to help us in guidance. And I hope the audience, the expert advice we're getting here is really important for our clinical practice. But I would just like to summarize this part of the discussion, because I think what we've learned is that there are symptoms and imaging findings we are not so familiar with, and I would really encourage the team here to come up with criteria, both imaging-wise and clinical, which identify cases which are atypical cases and which really profit from MR imaging, which is basically the goal also of our entire panel discussion. And I would like to switch gears a little bit here, because we also have experts from industry in our panel, and I would like to switch gear and try to understand what the drivers are from an industry perspective in promoting MR for imaging of osteoarthritis. And I was hoping that Maggie, you can maybe talk a little bit about MR. I know that GE is quite significantly involved in a number of osteoarthritis-related initiatives. There were arthritis-funded studies which were run with GE support. Can you talk a little bit about, from your personal experience, what's the role of MR imaging for osteoarthritis?
Yeah, so I think for routine clinical sites, most of them are using morphological imaging, with 2D fast spin echo. And people are pushing for higher resolution imaging to see smaller details like bone spurs, osteophytes, and things like that. So from a GE perspective, we are continuing to try to find new technologies to accelerate those scans, trying to push for higher resolution. And then on the research side, from the academics that we work with, including UCSF, Mayo Clinic, and Hospital of Special Surgery, for example, there are a lot of interest in using quantitative imaging to look at the composition of the cartilage, such as T1 Bro, T2, T2 star type techniques. So we see a lot of interest there, and we're also developing pulse sequence and protocols in those regards. And we have been trying to support clinical trials in either imaging trials or like the Kiva initiative to try to study those compositional MRI methods, and hopefully we'll find a way to see whether those compositional MRI method would be ready for prime time, so to speak. So that's the direction that we're going with.
Maggie, you guys were the first ones that made T2 measurements, T2 relaxation time measurements available for as a tool, as a commercially available tool. I mean, right now I think it's the only compositional technology which is really available commercially. And this has been around already for some time. And I was wondering, what's the feedback you're getting? How is the product taking up by the general radiologists? Is it something which is highly attractive? Is it so from your perspective, is it something which still is not considered such high priority?
So I would say usually we see it used more in high-end academic institution where they're really looking at earlier degenerative changes. I've seen it used in obviously research settings, but also sometimes in clinical setting where they see knee pain, but they don't see any morphological changes, then they will do a T2 mapping to see if they can see additional cartilage degeneration. But I think right now the scan time is still quite long, and that is hampering the general uptake of this technique in clinical settings.
Yeah, what I always felt was really necessary, and we did not have at this stage, was that it is a lot of time. It costs a lot of time to segment these, and when we do in a clinical setting to segment them, it takes one of our specialists quite a long time to do this. Now, however, I know that you have a specific interest also in artificial intelligence, and manufacturers have interest in these. And I think this would probably be a game changer. So for example, if you would get the sequence and then you would have AI just segment the cartilage, measure the T2 or T1 row or whatever, and then provide the data directly to the radiologist and to the rheumatologist or orthopedic surgeon. Is this something which is just a vision, or is this something which you think is actually doable in the next couple of years?
Yeah, I think definitely is something that we're looking into, especially with Shamila's group at UCSF. And there's been a couple groups that uses the OA data out there to look at cartilage segmentation, and the performance are actually getting pretty good. And I think the utility of it would be twofold. One is to look at cartilage thickness map. So for example, one of the panelists mentioned about presentation to the patient to see, or to the surgeon to say, where exactly do you have thinning cartilage? So using AI, you can be able to visualize that, but also putting that cartilage segmentation into the quantitative map so that you can easily quantify segmentally what are the values in each of the segments. So I think the field could be moving into that direction, and it is something that we're actively looking into.
Because I think that would be the game changer that is needed right now. I've seen, we started when we analyzed the osteoarthritis initiative data, it took us so long to which is not clinically feasible. It's feasible in a research setting, but not clinically. But let's move on and talk to Ruth and get the Philips perspective. And from your perspective, Ruth, as a very experienced researcher in MRI and a clinical scientist for Philips, so what are the developments Philips has planned for osteoarthritis imaging? I mean, there are lots of compositional technologies. There are also morphological sequences which could be used for segmentation of cartilage thickness, for example. What are the plans and developments that Philips envisions in this field?
Before I'm going into the details on OA imaging, I would like to emphasize that over the years, high resolution, high quality joint imaging has improved tremendously. So there have been lots of technical developments related to coils, related to pulse sequences, which in general made the image quality much better compared to a couple of years ago. And we continue to improve the general quality of MRI images of joints, not only the knee joint, but also the hip joint and other joints which might be important for such a situation. For the AI, I would like to underscore what my colleague from GE was just telling. It's mainly morphological imaging, but we see indeed in a research setting emphasis on quantitative imaging. And your KIBA initiative is really focusing now on T1 row and T2 measurements. And from our perspective, these are the most promising biomarkers. But we need to do a lot of research to make it more practical. The scanning should be more practical. Technologists should be able to do this as easy as regular morphological imaging. Segmentation should be automated, and also the scanner should directly output quantitative maps. And these are a lot of engineering steps we need to take, but these are important to make the step from current usage to a more versatile usage. But another aspect I want to mention is there are also developments for MRI related to bone tissue contrast. Of course, MRI is known for its soft tissue contrast. More and more techniques are nowadays become available, albeit in a research setting, to look at cortical bone. And I think if you have one imaging modality which can provide the information, you can do, I think, a lot more to discuss and to study the topics you guys have indicated.
But now, as a clinical researcher, of course, I would like to nail you down a little bit of when do you think these tools would be available? How would we be able to get these tools, or when would we be able to get this tool? Do you think there's a timeline, or is it too early to say?
No. In a research setting, these are available, not as 100% optimal as I would like them to have, but for an academic research setting, you can do T1 row, you can access whatever the new developments are. I'm not worried about the research setting, but the clinical utility has to be proven, and I think vendors are closely monitoring what's going on in the field, and as soon as there is evidence that it is useful, I'm pretty sure they will follow very, very fast.
So that's okay. That's back on us. We have to demonstrate the clinical utility of the technologies, and then you should think that industry would follow up and make these tools available to us.
And also indicate the standard. There are so many possibilities to measure certain elements. As a vendor, we can never implement all those flavors. So we would love to see that there is amongst the medical community consensus on how to approach certain features. And I'm really happy with the initiative of KIBA, where at least for T1 row and T2, there is now a consensus on how to measure that. I think that will help vendors enormously, because then they know exactly what to implement and how it can be used in clinical practice.
Yeah, that's good to know. Thanks. This is extremely helpful, because the KIBA initiative is a lot of work, and I really feel very good that you're saying this is useful information for also the manufacturers to understand what's important and what are potential tools which can be used in the future as standard tools, also commercially available. And let me move on and talk to Xiaodong, who is our Siemens representative. And Xiaodong, I mean, Siemens was in the early stages of the osteoarthritis initiative very involved. So all these scanners that are used for the osteoarthritis initiative are Siemens scanners. And I know that in the early phase, you did a lot of work standardizing the protocol. So you laid the stage for doing more, not only morphological, but also quantitative imaging. And for me, it would be important to hear a little bit about what was the motivation originally of Siemens to participate in this initiative, and also what did Siemens learn participating in the osteoarthritis initiative?
Yeah, thank you, Thomas. I think this is a very interesting question because, in fact, this osteoarthritis initiative happened before I joined the Siemens. So what I'm talking about here, then, it's not my, it's not like what I experienced, but through the relevant discussions in Siemens and also what I knew. Through the chats with the colleagues. And I think the most credits should really go to my former colleague, Dr. David Purdy, who was the member of the OAI imaging working group of the initiative. And he really contributed the most in Siemens for this study. So I think, first of all, Siemens is really devoted to supporting our customers for their work needs as much as we can. And the OA, of course, as we are talking about today, it's a very important MSK disease that is important for both the clinic and research fields. So naturally, Siemens would like to be part of the OAI study and also to contribute. And in addition, because all scanners used in the study were the Siemens scanners from 4 different sites, so we were all very honored to provide the scientific and technical support, and especially the MRI imaging protocols and the parameters, the optimization, and also the standardization. I think it was, I learned that it was quite difficult at that time because that's back in 2004 or 2005 year. So at that time, 3T was still quite new. So actually, it was not easy to optimize the protocols for 3T. And I think in the end, it was quite successful. The studies, all the protocols were set up quite nicely, and the working group were able to really acquire more than, well, I think close to 5,000 cases of the data, and they are in very good quality and still available for the research society to access and to do further studies based on the data. So I think that was quite good. And at the same time, I think we could certainly do better now because nowadays we have all the fancy acceleration techniques and different new techniques even. So we could even add more on top of that. But the OAI study, in my opinion, it's of course very successful, and we are glad that Siemens contributed a lot in this study.
Thanks very much, Xiaodong. I think that's important information because I think that was really for many of us a framework to have high quality data sets to work with, and a lot of the information from the Osteoarthritis Initiative is really setting the stage for a lot of future work, and it's an incredible database. Xiaojuan, you're an expert in imaging and also in quantitative imaging. I was wondering if you could give us a little bit of an idea in terms of methods. I mean, we've heard a little bit about T2, commercially available technologies, and I wonder whether you could share some of the important information about these quantitative techniques, compositional techniques, and how would you prioritize them? And where do you see weaknesses, strength, and what is your recommendation as an imaging researcher?
Okay, sure. Thank you, Thomas. Yeah, I'm really excited to be part of this panel discussion, and I really enjoyed the talk from the clinician, from Frank and Tuhina, and the discussion from all the clinicians, and now the discussion with all the vendor representative. That's really, I think we open up several questions here that when we focus on the quantitative imaging as a researcher, that one thing we got excited is about developing like a really new technique, find out the new contrast, and find out really like a novel marker for potential detection of early degeneration. That's one part of our job and life. But I think the more I talk to clinicians and the more I realize, and I think the field also also realized that from the the development of new technique to the time that the technique can be used clinically, there is a long way. And some people need to make efforts to push that forward. And I think that's the motivation for our KIBA MSK committee and our first profile work on the T1 Rho T2 imaging. And that, as discussed by already several, by our vendor representative, one key thing about making this potentially clinical available is about standardization. So there are just so many techniques, and there are also detailed difference between vendors. So for the previous research study, the reproducibility, repeatability has been tested, but most of them are on like a single site, and some are multi-site, but single vendor. So really there is a very few work that has been tested, this compositional or quantitative imaging across vendor. And if we really want to push the usage of this technique in a large-scale clinical trial or in the clinical practice eventually, that I think to have this cross-vendor validation and evaluate, document the variation and mitigate such variation would be one thing we should work as a field. So I really, again, happy to see we have the industry representative. All of them are also very supportive. I really also appreciate support from Maggie, Ruud, and Xiaojuan to our multi-vendor imaging efforts. Through KIBA and with the support from Arthritis Foundation, we have done this pilot study doing this multi-vendor variation evaluation of T1 or T2. The current result is promising. So we have a little bit higher than 10% variation of T1 or T2 across 3 vendors, but that is using same structure of the sequence. So if we include sequence with a different structure, that variation can be up to 20%. So one message here is when we talk about quantitative imaging, first thing is you need to use the same sequence structure. Second thing is you need to do this cross validation. And a third point is to have a calibration phantom is also a key. And that is another thing that currently is lacking in our field. So that is another efforts now we are making, and as a part of the aim of the, we have an active ongoing R01, and we are working, collaborating with NIST and the Phantom company on doing some research prototype of this calibration phantom that is going to be dedicated to MSK quantitative imaging. So I think with that, with the standardization on sequence, on data acquisition and post-processing, the fitting method is also important. You can get different values with different post-processing as well. And with the calibration phantom, then that's the first step about this standardization. And another hurdle that, again, I agree with all the previous discussion, other hurdle about using this quantitative imaging is about long acquisition time. So nobody will want to put a 10 or 15 minutes like a sequence to their clinical protocol. Currently, the knee protocol is about 20, 30 minutes at the most at clinical site. And so as like a research field, we also made a lot of efforts in the field about this fast imaging, as well as all the industry vendors. So we need to make it fast. And then we automated post-processing. So again, nobody will use it if you need 1 or 2 hours to segment the knee. That is either looking at the thickness or looking at the composition. So fast imaging and automated post-processing will be also the key to make it really happen. And lastly, I think it's about accessibility. So for this technique, at this moment, for Thomas, you mentioned T2 is the only clinically available composition technique. Actually, some people may argue that degenerate is also clinically available because T1 mapping is clinically available. So you can literally also do degenerate, although there's a hurdle about the contrast agent injection and long waiting time and other factors. But if we talk about there's a non-contrast compositional technique, T2 is the only one. And T1 Rho for the vendor, all of them have the research prototype, but it's not a product. And only high profile like academic site can do it. So I think that's accessibility, and combined with the education you were talking about, not to specific to this quantitative imaging yet, but I feel only we can make this happen like as a product in the efforts with the industry vendor and the academic site, then more people have access to use it, and then combined with education, probably then people can have more clinical, this imaging technique can have more clinical impact on it. And I also like what Drew pointed out. Fortunately, that at UCSF, that even in a clinical setting, you do have the capability to have a TRO T2 imaging. We actually did some survey with the orthopedic surgeon at UCSF, and all of them gave very positive feedback. Once you have the provide information in front of them, then they love it, right? And the patient love it to see the color map. And actually, Rick Kichowski from Medicine, he published a paper on adding the T2 in a cohort about 200, 300 patients, and shows that improve the sensitivity of diagnosing very early cardiac degeneration. So I think there's a lot of opportunity and exciting potential, but there's a long way we need to do as a field.
Yeah, thanks very much, Xiaojuan, for this summary. This was great, and thanks so much for your enthusiasm about the technology. So we have one question from Kurt Spindler. I know this is Kurt, Xiaojuan and Kurt work together at Cleveland Clinics. So Kurt is going back to the clinical part of our discussion and mentions that one of the confounding problems related to structural changes with patients' pain is activity level, and it's not controlled for. If you have early OA and don't perform high impact activities, then usually you have minimum symptoms. This is something which is really important. And Kurt, do you just want to go a little bit into more detail, because I think that should be discussed between Drew and Tuhina?
Well, I think that we see people that have early structural changes in their knee, and then they begin taking on some high impact activity. They decide to do a running program, or they decide to go to a boot camp, or they decide to do some high jumping, and then they get pain. And then part of the treatment is you may wind up using something, exercise. Well, a big part of the treatment is cutting back on the amount of activity they do, and seeing if you can get to a level where they don't have pain within their knees and their joints. Well, let's talk about their knee. And so, I think that we see this when we MRI'd 60 knees that were 2 years after ACLs, and we haven't reported much on them in the Moon cohort. The MRIs do not look pretty at all, and yet these individuals are functioning at a really high level, and their activity scores are high, and they have no pain, but they clearly have changes in their knees and how we follow them out. So I think it's something that one of the statisticians said, if you have coronary disease, you do a stress test. Well, if you have early disease in your knees and arthritis being a joint disease, we don't have a stress test. We haven't figured out. So how much exercise is too much? What's the individual amount of exercise? When does it relate to symptoms? That's something that it's a problem for us. And I'd like to hear Drew's comments on it, because I'm sure he deals with it all the time too.
Yeah, and Dr. Spindler, I think those are great points. And we, interestingly enough, have an upcoming paper in AJSM on activity after ACL reconstruction. And we noted that the patients with the higher MARC scores, they had more advanced cartilage degeneration as measured by T1 row mapping at, I think it was 3 years after ACL reconstruction. And so these people, they still feel good at that point, but we can already see some breakdown in the cartilage composition. And I think it's really important for us in advising these patients, and hopefully we can find ways to know like how much is too much, and then how much that knee can tolerate to be able to preserve the joint with good recommendations on what they should and really should not be doing after these types of injuries.
Great.
Yeah.
Great.
Thanks, Drew. Drew, you're also involved, we've talked about this yesterday, you're also involved in a new post-traumatic osteoarthritis trial, which is going to be supported by the Arthritis Foundation. This is really important in this setting. Can you talk a little bit about this trial and what kind of MR outcomes you're using for this trial?
Yeah, and so it's Cale Jacobs and out of Kentucky has coordinated this and really put in the legwork to establish it. And the goal will be to look at if montelukast administered after ACL reconstruction has a role in limiting the progression of post-traumatic osteoarthritis, and specifically in patients with ACL injuries and a concomitant meniscus tear. So we'll be following these patients with quantitative MRI, so T1 row and T2. We'll also look at semi-quantitative scoring, and then additionally doing bone shape analysis. And I think many of the investigators are on this call too, so it'll be a great collaborative group effort between Kentucky, UCSF, Cleveland Clinic, Duke, and some other locations, but should be very interesting locations or very interesting findings. And then Jason Kim with the Arthritis Foundation, I think has put a great amount of effort into getting us to this point to where we can hopefully see if this oral medication has a role in limiting that progression.
Thanks. I think we're getting close to the end of our discussion period, but maybe we just have a few minutes before I would like to summarize. But I would also, just to come back, as Drew has pointed out, we need also MRI as potential outcome measures for clinical trials. And I was hoping that, since Frank, you have done a lot of work in this field and you've published a lot on this, I was wondering whether you could just briefly, maybe in 5 minutes or so, summarize which, in your opinion, are the most important MR techniques to measure outcomes using MRI.
Yes, I'm very happy to do that. I mean, when we're talking about clinical trials, and I assume you think drug trials in this regard, or intervention, drug trials, demo trials, we are usually talking about patients with established OA, because right now I do not know of any clinical trial that is performing a demode exercise, so to say, in Kelvin-Lorentz 0 and 1 knee. So these, and you wouldn't treat, at least today, no patient with such very early changes. So meaning, in my very personal opinion, I think the role of these compositional techniques in such a population of, usually these are Kelvin-Lorentz 2 and 3 knees, meaning a little bit more early OA or moderate OA, these compositional techniques probably are not that important. And then, of course, it depends very much on the structure that is being targeted. And Tuhina pointed that out earlier as well. So some of these drugs or compounds may be anti-inflammatory, particularly working in knees or joints with active inflammation or persistent chronic inflammation. Some of them may target the subchondral bone, and some of them may be cartilage anabolic or anti-catabolic. And depending on those tissue targets, I think you need to define your outcome up front. And even more important, it is to discuss and think about which patients do you want to include. And we're doing a lot of work and focusing a lot on that topic right now, because we know that established OA is really, it's a mixed bag. Kelvin-Lorentz 2 doesn't mean anything. It just means there's an osteophyte. But I've shown you the MR images before. There's so much more to it, and some of them may have inflammation, others may not. So you probably should focus on subpopulations where your drug actually might show an effect. And again, depending on that, your MRI technique is important. But to sum that up in a more general fashion, I think if you're thinking about cartilage effects in a population with established or advanced disease, probably 3D segmentation tools are the tool of choice today, because they are sensitive to change. If you're thinking about other techniques, and particularly patient inclusion and characterization of patient samples or study samples, I think semi-quantitative scoring may be very efficient. And what also has been said, the role of bone shape, to use that as an outcome measure, is promising, but it may also, that's my, again, personal opinion, may be a surrogate for other things that are going on, and it's just a secondary factor that we see during the course of the disease. So I think it's very important to look at that more specifically than we have in the past. So we have certain patients that might be susceptible to certain treatments, and then we need specific outcomes to assess those treatment effects.
I think that's really important, Frank, that I think you have to tailor the study according to what you're testing. Like, for example, as Drew was pointing out, okay, there's synovitis, which is potentially an outcome. Then you have to use some synovitis measurements in addition to cartilage measurements. So I think this is really important. And We're running out of time now, and we still have to make a couple of announcements Jason has to make a couple of announcements. So I would like to summarize. So I think what we've done today was really laying the groundwork basically for using MRI in osteoarthritis. I mean, we've learned a lot. We've learned a lot, and we've also learned of our shortcomings. I think one of the shortcomings we've learned a lot about is, okay, what are these patients that would need MRI? What would be the specific criteria in atypical osteoarthritis when a patient needs to undergo MRI? And I think this is sort of also something where we know that we could develop these, and since we have an expert team, we should consider writing maybe a white paper about this, which would be extremely helpful for clinicians, for radiologists, for rheumatologists. But what we've also learned today is that a lot of teaching has to be done, that these criteria are not so straightforward, because, I mean, some people, general radiologists, may have a hard time interpreting the findings and may have don't know really what these means and what potential these diagnoses would have. So we need, and Tuhina alluded to this, we need these outcome studies over time to know, okay, what lesion is going to result in what, and what kind of lesions should, if you do corticosteroid joint injections, what lesions should not be injected to avoid progression of disease, as shown in Tuhina's case. We've also learned a lot about, from industry and the industry perspective, how important it is in terms of that we show that these tools are needed in order to motivate the development of these technologies. And I hope that KIBA is one of the ways to promote this and to standardize it and to make it more easy to use it. We've heard a lot about artificial intelligence. I think that would be extremely helpful in really facilitating analysis techniques, especially the quantitative one Xiaojuan has talked about. And finally, Frank has nicely summarized the clinical, for clinical trials, the tools that are needed. So with that, I would like to finish this panel discussion, and I would like to give Jason some time to make the announcement he needs to do. But I enjoyed very much talking with all of you. I think this was a very constructive, a very valuable discussion. We've learned a lot, and it really motivated me to work in this field and to really have new ideas what we can do really in order to prevent osteoarthritis through using imaging tools, through using MRI in special indications. And I hope you will take same things home for you. And with this, I hand over to Jason.
Thank you, Thomas, and thank you everyone for joining today's discussion. The panelists and the attendees, it was a really great session, and you know, Thomas organized such a rich discussion. I think based on some of the momentum that we had today, that maybe Thomas and the panel will be can consider a 4-hour section next time, which sounds like a lot, but based off of how quickly 2 hours went today, I think it might move pretty quickly at that point. I'd like to recognize some of our internal staff for helping with such a smooth program and promoting this session, but especially like to you know, send a shout out to Emily Hunt and Carolyn Lizzie, who really helped with a lot of you know, the logistics behind pulling together this panel. But also at this point, I'd like to announce the next session, which is titled Impact of OA in the Military and Veteran Community, and that's going to be led by Jody Buckwalter, and a pretty big and expert panel, and that's going to happen November 4th at the same time as today. If you've registered for today's meeting, you'll certainly receive an invitation for the next meeting, and I'll be dropping a link to the Forum Series website into the chat box, so you should be able to find all of that information there. So now we're going to be transitioning to the networking breakout sessions. We'll give a bit of a short break to allow people to drop off and anybody to get a drink of water or go to the bathroom. And at that point, we'll have no recording, and it'll just be for connecting with colleagues and making new connections as well. So I encourage you to turn on your video, introduce yourself. It's an experiment in socializing in 2020, so I hope that'll help with some good spontaneous interactions. So I hope you guys will stay on and join that session.